Hello, and welcome to the DSERA Clinical Education Infectious Disease Podcast, formerly the CCO Infectious Disease Podcast. I'm your host, Kristen Formby. Today's episode is the first of three taken from our live event on carbapenem resistance in critically ill patients. In this episode, we discuss how to optimize antimicrobial regimens and develop evidence-based antibiotic management plans for complex infections caused by carbapenem-resistant bacteria. This episode covers reassessment of carbapenemases and antibiotic selection. I'm joined by Dr. Marin H. Kollef from Washington University School of Medicine in St. Louis, Missouri. To follow along with the slides, please visit the show notes for this episode.
I'll start with a case, a patient that I took care of. This patient was admitted from a nursing home after having a witness seizure that lasted roughly 2 minutes. Was treated with Keppra. EEG showed diffuse slowing. You can see the vital signs there, relatively stable, good sat. The patient had been hospitalized 3 and 7 months earlier with the trach in place for what was thought to be tracheobronchitis and was treated with antibiotics including vancomycin and meropenem during those hospitalizations. In addition, received other antibiotics at the nursing facility. And our plan at the hospital was just to discharge this person after about 48 hours of observation and having seizure meds started. The chest x-ray, which you saw before, looked relatively clear. However, on hospital day 3, we have this new chest x-ray, and it appears that there's some infiltrate in the right lower lobe and on the left side. The patient also now has secretions coming out of the trach. They're purulent. The patient also has more labored breathing. You can see the SaO2 has dropped while on 10 liters. The vital signs suggest that the patient's somewhat unstable. Blood pressure's down, respiratory rates up, temperature's up. So the patient is transferred from the trach floor. We happen to have a trach floor in our institution, and they go to the ICU. Patient gets a cuffed trach at that particular point, is placed on a ventilator, and then the house staff, along with the fellow, start antibiotics. In this particular case, vancomycin, 1.5 grams, and meropenem, 1 gram are given IV. And a tracheal aspirate is sent off after the trach is changed for multiplex PCR testing. And we happen to use the BioFire test at Barnes-Jewish Hospital. So going forward here, this is the BioFire. You're all very familiar with it. It's a multiplex PCR allowing for the detection of multiple bacteria as well as viruses, atypical bacteria, and resistance genes. There's also the Univero, which is another very similar multiplex PCR, again, looking at a number of different resistance genes, bacteria. This one also allows pneumocystis to be detected. And so it's sent to the lab. The tracheal aspirate is sent to the lab, and after 6 hours, we get a call, and it comes up on the computer, Klebsiella pneumoniae, and the resistance gene that's detected is NDM. So this patient's condition worsens with need for 100% FiO2. They're on the ventilator. They need vasopressors at this particular point. So the question is, what do you do now? And so, you could debate, is this a hospital-acquired pneumonia that now requires ventilation, or is it someone who comes in from the community? We're not going to debate that point, but we need to come up with a regimen to treat this person. So would you continue the current regimen, which was vancomycin and meropenem? Would you give 1 dose of IV tobramycin? Would you switch the vancomycin to linezolid, switch the meropenem to ceftaz, avi, and aztreonam, or add nebulized colistin? Okay, so really it's a matter of looking at the picture here in terms of this particular case, and in general when making decisions about antibiotic selection, one needs to get some information about organisms. We can get that more quickly now with some of the multiplex testing. We need to understand the site of the infection. Obviously, pneumonia being different from urinary tract infections in terms of the potential drug delivery aspects as well as pathogens and susceptibilities. The prevalent resistance mechanisms in your institutions and in your community, and other patient-specific factors, like in this case, the trach and the patient having received multiple prior courses of broad-spectrum antibiotics. And these are actually the 2024 IDSA recommendations that they put forth on using antibiotics for particularly resistant organisms based on the presence of specific carbapenemases. And so you can see for KPC, which is a class A carbapenemase, you're likely to have resistance to multiple areas here, penicillin, cephalosporins, carbapenems, and aztreonam, IDSA recommends ceftazidime avibactam, meropenem vaborbactam, or imi-rel. Those would be the three choices. There are alternatives that are there, cefiderocol, tigecycline, ribavacycline. Problems with the latter two, being tetracycline derivatives, are that the registration trials suggested some problems with the treatment of urinary tract infections and bloodstream infections. So you would probably avoid those in those particular circumstances. When you get to Class B, and that's the case for our particular patient here because they had an isolated NDM carbapenemase, that's NDM, VIM, and IMP. Really what IDSA recommends here are ceftazidime, avibactam, and aztreonam, or cefiderocol. Those are really the two agents there for that particular class of resistance. Again, tigecycline and ribavacycline one would consider, but avoid if you had UTI or a bloodstream infection. And for OXA48, where we can see this in various pathogens, Acinetobacter, Pseudomonas, again, you have a broad spectrum resistance. Drug of choice here by IDSA is really ceftazidime avibactam based on its overall activity, and then cefiderocol would be an alternative. Just continuing here, in this particular case, our patient was switched from meropenem to ceftazidime avibactam and aztreonam once we identified that the patient had NDM and had a essentially severe pneumonia that we had documented. Disc diffusion results returned 36 hours later, and these are the results. So one of the key points here is that we got information relatively quickly with the multiplex PCR. You can see the disconnect here, almost more than 24 hours since, or delay, if you will, if you were waiting on just the disc diffusion or the microlab to get back to you. And we can see resistance to ceftazidime, meropenem, colistin was susceptible, amikacin was intermediate, ceftaz-avi was resistant. So that's really key here. You know, we're dealing with the NDM, we're dealing with an organism that will be resistant to aztreonam, or excuse me, to ceftazidime avibactam, but the addition of aztreonam confers susceptibility. And then ciproceptolazone tazobactam was resistant as well. When we made the switch in this particular case, although it took a while, this patient did recover, and after about 3 weeks in the ICU was eventually able to get back to their long-term acute care setting. So mechanisms of resistance, again, this is really sort of the breakdown. You know, we need to be aware that we sort of focus on carbapenemases, and we've already talked about the three classes of carbapenemases that are listed here for you. But also keep in mind, many pathogens can have a phenotype of carbapenem resistance without actually having a carbapenemase. Case in point being Pseudomonas in the United States, either because of high-level expression of ESBL or AMP-C, plus the deletion or modification of a porin channel. So one has to understand that even if one comes back with a negative result on the multiplex PCR, particularly for Pseudomonas, one can still have a phenotype that is carbapenem resistant. Now, focusing specifically on NDM, the data suggest, and those of you from New York and other places where you're seeing a lot more of this, this is an increasing and escalating problem throughout the US. These are just data from one proprietary database in the United States from 74 medical centers. And you can see what's happened here from 2019 to 2021. And when you look at the metallo-beta-lactamases in the middle here, which would include NDM, VIM, and IMP, the numbers are going up, and they're significantly going up. More importantly, if you look at data from the CDC, one can see that their resistance lab has seen almost a 500% increase in the numbers over a relatively short period of time, roughly 4 years. And in New York City, and those from you from New York can hopefully confirm this, NDM has surpassed KPC as being the most common carbapenemase in 2024. So we're seeing, as we have seen over the last decades, changes in the spectrum of organisms, and more importantly, their resistance elements. This is just a review for you, looking at carbapenemase producing the Enterobacterialis, and really, you know, the antibiotics that would confer activity here. When we're talking about cefiderocol, you can see it covers across the board. Ceftaz-avi primarily for KPC and OXA48, ceftaz-avi plus aztreonam across the board. And then you are left with the antibiotics that primarily are going to be treating KPC, which is imi-rel and meropenem vaborbactam. Again, the combination, which is the newest combination that we have here, although prior to this drug being released, we were sort of doing it on our own by combining two different antibiotics. ceftazidime, avibactam plus aztreonam for metallo-beta-lactamases. There are a number of studies now. They tend to be more smaller case series, if you will, and a lot of them come from Europe. And these are a couple of studies here from Europe, one in the US, that make the point that when you look at these antibiotics and the ability to treat relative to alternatives, the use of ceftazidime, avibactam plus aztreonam achieves higher rates of clinical cure, if you will. So there are advantages in using this for this particular type of an organism. Now, there's some additional considerations here when you're dealing with the metallo-beta-lactamases. Based on results from surveillance studies in general, more than 90% of these will be susceptible. And you need to be aware that many of your labs may not be reporting susceptibility results for these particular organisms to you. So if you're using a microarray and you identify an NDM in the respiratory tract, one has to make a decision at that point. And it's really a little bit of a leap of faith in terms of picking a drug that you think is going to be active against it. And we've already talked about the antibiotics that are most likely to be active against it in this particular case, which would be ceftazidime, avibactam plus aztreonam, or cefdiericol. Cefdiericol for the metallos, again, there are some studies here. Just to summarize them, if you focus in the graph down in the corner here, it's important to understand that the drug can work with these particular organisms. There's the credible study as well as a nosocomial pneumonia study that was done. The issue is that when you look at overall cure rates here, the cefdiericol cure rates were in the rate of about 30%, and the mortality was roughly 30%. And the ceftazidime, avibactam plus aztreonam mortality was roughly 22%. They did better than some of the comparator regimens. So overall, those are the drugs that seem to be most active against this class of organisms. Cefdiericol, some additional considerations. I mean, it's been looked at in systematic reviews now and meta-analyses, taking into account a number of different studies. The cefdiericol non-susceptibility rate for metallos was about 13%. So it tells us that the majority of these organisms will be covered. So we have these two antibiotics now that we can use for this class of resistance, which is escalating in the United States. And again, there is an issue with susceptibility from your microlab. If they're using disc diffusion methods, they really need to have the Mueller-Hinton broth in order to, because when you talk about cefdiericol, it requires iron, sort of the Trojan horse approach, in order to get its way into the bacteria. So the lab has to have the capability for testing for this in terms of its susceptibility. And you can see resistance, just like you can with ceftazidime, avibactam, aztreonam. It's uncommon, and it has to do with mutations at the penicillin binding 3 protein. Tetracycline derivatives, I've already covered this. Not to go through it in detail. These drugs have been around for a while. They can be effective. The problem is when you look at the registration trials, they didn't do as well with urinary tract infections as well as bloodstream infections. So one just needs to be careful with their use given that we have alternatives, and the alternatives which I've already discussed. So there are a couple of take-home points. I think, the number one is that CRE is not KPC, okay? CRE really refers to the broader group of organisms, the Enterobacteriaceae, that will have resistance to carbapenems, whereas KPC really speaks to a specific carbapenemase gene. And so, we're talking about a class A gene for KPC, and those antibiotics that we would consider based on IDSA recommendations, ceftazidime, avibactam, meropenem, vaborbactam, or imipenem, celastin, relebactam. For the metallos, where we have NDM, VIM, and IMP, NDM being the one that's really sort of raising its head in the United States, ceftazidime, avibactam, and aztreonam, or cefdiericol. And finally, for OXA48, IDSA really recommends ceftazidime, avibactam.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To listen to the other 2 episodes, please click the link in the show notes. To get access to all our new podcasts, subscribe to the Dacira Clinical Education Infectious Disease podcast on your favorite player. Thank you and have a great day.